I've been invited to talk about antivirals and challenges in developing antivirals for CMV infection. And my talk today will be restricted just to antivirals for CMV.
Reposition your mic a little bit.
Okay, is it better now? Okay. Just to antivirals that are used for CMV prophylaxis, not to CMV vaccines, peptides, and all the other good stuff. So with much ado, let's go on to the background. Most of this has probably been discussed with you by Dr. Avery on the first day. So we will go through this rapidly, but it is necessary to have a coherent talk. So CMV infection in the HSCT population, that is hematopoietic stem cell transplant subjects, formerly known as BMT or bone marrow transplant subjects, is associated with considerable mortality and morbidity. The highest risk patients are those who are seropositive for CMV, and in those individuals, about 70 to 80% of them come down with CMV infection. And here at the outset, I'd like to clarify the terms infection versus disease. Infection usually refers to any evidence of CMV replication, whether it is by picking up CMV DNA, CMV RNA, protein, or the virus itself, while disease refers to CMV infection that is associated with symptoms of a particular organ system or more than one organ system. So if untreated, 20 to 30% of these subjects will go on to get CMV disease, and that is a large number. So accordingly, two preventative strategies have evolved over the years. One is, of course, prophylaxis, which is like prophylaxis for any other organism in the HSCT setting. The other that is a little unique, not unique, but it's a more frequently practiced in this setting is preemptive therapy, which is a practice of actively surveilling for viral replication. And when viral replication occurs, then one comes in with anti-CMV drugs to treat the viremia so that it doesn't progress to CMV disease. All currently available anti-CMV agents, they act on the DNA polymerase, and they have significant toxicity. Just listed here very briefly, ganciclovir and ganciclovir. They are associated with myelotoxicity, which is very relevant in the HSCT setting. Foscarnet is associated with renal toxicity and or electrolyte imbalances, and cidofovir is associated with both. Because of these toxicities, in order to unnecessarily treat a lot of patients who may not need the prevention, PET is the primary modality of prevention that is used worldwide. There are some centers that do use prophylaxis, but more than 90% of centers worldwide use PET. And to date, PET has worked like a charm, in that the rate of infections have come down to between 20 to 30%, and the rate of disease is now down to between 1 and 5%. However, there still remains to be a little bit work done with PET, in that recent studies have shown that any level of viremia is associated with increased mortality, even after one adjusts for PET. And PET basically operates on the assumption that you will have viremia when you start PET. Thus, there is an unmet need for a prophylactic agent that is well tolerated and efficacious in the HSCT setting. So here are some of the agents that are in development currently. As you see, the agents that we referred to, they act on the DNA polymerase, affecting DNA synthesis. Brincidofovir is one new agent, a lipid derivative of cidofovir, which has recently been evaluated for this purpose. It also acts on the DNA polymerase. Letermovir has a unique mechanism of action in that it acts on the viral terminase complex. So when the CMV DNA is replicated, it's usually a polymeric segment of many unit length segments of DNA, and the terminase complex clips this newly synthesized DNA off into unit length segments, which are then packaged into provirions. And The third one that we're going to talk about today is marabavir, which acts on the UL97 kinase. And by doing so, it prevents maturation and the release of CMV virions. I'm not sure why it's going like that. All right. So let us start with marabavir. So marabavir went through a phase 2 study like any other drug, a dose-ranging study, and based on the doses that were evaluated in the study, a dose of 100 milligrams twice a day was selected for this phase 3 study. In this study, subjects were allowed to engraft, and once they had engrafted, they were enrolled in the study, and they got 12 weeks of marabavir. The primary endpoint was CMV disease, and subjects were followed up all the way up to week 24. CMV disease at week 24 was a primary endpoint. In the event of patients reached the primary endpoint earlier, meaning that they failed on prophylaxis, they were treated with preemptive therapy. Here are the results of the marabavir study, and as you can see, the incidence of CMV disease was no different in the marabavir and the placebo arm. There was no difference with all-cause mortality. So the primary endpoint was not met. As far as CMV infection goes, if you looked at it by DNA PCR, again, no difference between the two. There was a little bit of difference if you looked at it by PP65 antigen anemia. The main criticism of the study from everybody was that the incidence of CMV disease was extremely low, that selecting disease as an endpoint was not realistic, as you would require unrealistically large samples to show a reasonable difference between the two groups. However, regulators until this point were not conducive to accepting CMV viremia as a surrogate endpoint for CMV disease. They wanted a hard point like CMV disease or all-cause mortality. So after this trial with marabavir, Chimerix, which develops brincidofovir, and we, who developed letermovir, we worked with the regulatory authorities, and we came up with an endpoint that is usable with a reasonable number of patients. And the endpoint in both our studies was identical. It was clinically significant CMV infection. And clinically significant CMV infection is a composite endpoint consisting of CMV viremia that requires PET and or disease. As you can see, the design of the phase 3 marabavir trial, subjects got 100 milligrams twice a day of marabavir until week 14, the period of highest risk for CMV infection, and thereafter they were followed for another 10 weeks to assess the durability of the response. So, week 14 is basically the cutoff for the period of highest risk. In some slides, you will see it as day 100, and others you'll see as day 98. I will refer to them all as week 14. Likewise, 6 months or 24 weeks is really the endpoint for the primary endpoint, and you'll see different days in the slides. So, in the period of highest risk, the first 14 weeks, brincidofovir works very well. The two curves, the placebo and brincidofovir, they separate very well. And there is a difference of about 14% between the two groups with a p-value of 0.02. So during the treatment period, it worked very well. The trouble arose in the follow-up period when subjects were being followed off brincidofovir. And as you can see, the proportion of subjects with CMV, clinically significant CMV infection, progressively went up until there was no statistically difference between the brincidofovir arm and placebo. Thus, brincidofovir failed in a study using this endpoint. And the primary explanation for this was that one of the side effects of brincidofovir is diarrhea, and a lot of patients in the brincidofovir arm had diarrhea. The PIs had been given instructions how to deal with diarrhea, but these patients being as sick as they are, the usual standard of care was used, which is that they were started on treatment for GVHD, which includes, of course, steroids, and immunosuppressants. And because of a lot of diarrhea that may not have been related to GVHD, patients got treated in the brincidofovir arm. More patients got treated for GVHD, and that may have resulted in increased CMV reactivation. So here's another challenge with drugs that one wants to develop for CMV prophylaxis, in that the side effect profile, if it is such that it looks very similar to other complications that would occur during the development of the disease, that could interfere with the observed outcomes of the study. So there's the study results summarized over here, that through week 14 you saw good efficacy. Then the efficacy started wearing off as you went towards week 24. Similar pattern seen with mortality, and this was probably due to increased incidence of GVHD in the brincidofovir arm. Now to letermovir, which is our pivotal phase 3 study. The design is pretty much the same as the one that was used for brincidofovir. Subjects were treated for the period of highest risk up to week 14. They were followed up for another 10 weeks up to week 24 for the primary endpoint. And thereafter, there was a long-term follow-up for other things like CMV disease and mortality and health-related outcomes. But the primary study period was up to week 24. One critical difference between us and brincidofovir was that we have both the oral and the IV formulation of letermovir. So we did not need to wait till subjects could tolerate oral intake. They could be started as early as the week of transplant, and as you will see later, a lot of subjects were started very early in the course of the disease. So this is a first for drugs that are being evaluated for CMV prophylaxis. The primary endpoint, as we discussed, was a composite endpoint of disease and viremia that required PET initiation. And here are the results of the primary endpoint. As you can see, the proportion of subjects who got clinically significant CMV infection through week 24, the proportion of subjects who met the endpoint was 17.5% in the letermovir group compared to 41.8% in the placebo group. This primary analysis was done by what we call as a non-completer equals to failure approach, where not only subjects who had clinically significant CMV infection were considered as failures, but if subjects discontinued the study before 24 weeks post-transplant, or if the data during the week 24 visit window period was missing, those subjects were also considered to be failures. So the proportion of failures that were seen at week 24 was 37.5% in the letermovir group compared to 60.6% in the placebo group, giving you a difference of 23.3% between the two groups with the p-value that you see. And this is graphically demonstrated. Like brincidofovir, things went very well till week 14 with a very nice separation between the two curves. After week 14, there is a little bit of a rebound in the letermovir arm, but not to the extent that it was in the brincidofovir arm, and a considerable amount of difference was maintained along with a p-value of 0.001. This was the case also with mortality, seen here through week 24. Lower curve letermovir, upper curve placebo, and there is a difference of about 5% with a significant p-value. Same thing with mortality at week 48. The absolute difference was about 5%. P-value was, well, this is not quite right. The p-value was not significant. It is actually 0.189, not 0.189. And that was to be expected as you go longer in a study, more and more patients die, and then there are fewer patients to compare with, and you're less likely to pick up statistical significance. Safety. So shown here is a summary of the safety profile. So basically, the proportion of subjects with all kinds of AEs in the letermovir group were comparable to subjects in the placebo arm, with one exception, and that was the AEs that led to discontinuation, which was much greater in the placebo arm than in the letermovir arm, and this was because you got more CMV infection in the letermovir group compared to this letermovir group. The most common AEs that were seen, they're consistent with the known side effect profile of letermovir, which is mostly gastrointestinal disorder, so there was nausea, vomiting, and diarrhea. Though these were the most common AEs, the numbers were comparable between the two groups, between the letermovir and the placebo group. Others were things that you see in this subpopulation, like fever and graft-versus-host disease. Then, of course, there was CMV infection, where there was a difference between the two groups, and rash, which is also seen with letermovir. The drug-related AEs, there were very few drug-related AEs, mostly the gastrointestinal AEs. They were considered, and these were evaluated by the causality was evaluated by the investigators, and they considered about half of them to be related to letermovir use. Other than that, they were all comparable. And finally, to the issue of engraftment. So as I had mentioned before, 2/3 of the patients in the study were enrolled before they had engrafted. And we looked at the subjects in the letermovir group versus placebo, how they did with respect to engraftment. 95% of the people in letermovir engrafted compared to 91% in placebo, and there was no difference between the time to engraftment, which was 19 versus 18 days. So this is a first for a CMV prophylaxis drug, that it can be used as early as a day of engraftment without engraftment being affected. It is a concern amongst HCT physicians. So to summarize, letermovir is highly efficacious. Through week 24 post-transplant, there's a 40% reduction in clinically significant CMV infection, with a number needed to treat of 5. There was also significant mortality benefit, 33% reduction in all-cause mortality at week 24. It continues through week 48, and the number needed to treat is 18. The safety profile is similar to placebo, and there was no evidence of milder toxicity, which is particularly pertinent in this patient population, nephrotoxicity or hepatotoxicity. So starting with an endpoint of CMV disease, which would require a huge sample size, we worked our way up to an endpoint that is a composite endpoint of clinically significant CMV infection. We have eventually now reached a stage where prophylaxis with an agent that can be given both orally and intravenously can be efficacious and is safe and well tolerated. This drug has recently been given a breakthrough therapy designation by the FDA, and it is expected to result in a shift in paradigms in treatment guidelines for prophylaxis and prevention of CMV infection. Thank you.